next speaker is Dr. Mallika Goyal, and she'll be speaking on fibrin glue for closing retinal breaks in complex retinal detachments with silicone oil in situ.
Good evening. Bali, you saw this last year, but since then the indications have expanded and cases are different and many more. So we'll be seeing something different from last year. I hope they'll be able to run the videos. The last session they could not.
Slide. We're trying.
Fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ. It's not advancing. Yeah. So this has fibrin glue has been used in simple retinal detachments to close breaks, but there it is used to avoid the use for any tamponading agents. It has not been reported for complex detachments with silicone oil injection. So our first case was 2 years back where we operated a complex PDR-RD, and there was a lot of SRF because of an open break in the superior mid-periphery. So we went in for resurgery for this, did membrane peeling, tried to aspirate the SRF, but the break remained open and was not amenable to laser. So at this point we injected fibrin glue over the break. The oil was already in the eye because it was an operated eye, and we found to our surprise very rapid retinal reattachment. So encouraged, and this same case after 2 years now, doing very well, no long-term complications with oil in the eye. Oil was still in the eye till recently. So we encouraged by this, we did several other cases. This is another patient with the PDR complex RD recently done. So as the membrane peeling proceeded, finally there was a break in the superior to the macula, and this was not amenable to laser. We tried laser, so finally we injected glue over the break, as you see here. And you can see on the first post-op day, glue is seen, but the retina is attached, and within few days the glue is gone. And this is more recently the same patient doing very well. Another patient with a massive membranes over the posterior pole, PDR, and towards the end there was a break which was not amenable to laser. So again we injected the two components of the glue sequentially over the break. And you can see 1 year later the patient is still doing well, oil is still in the eye. There is no emulsification, no complications, and one-eyed patient. Okay. This was, yeah. Can you run the video please? No. Okay. So we extended this to non-diabetic retinal detachments, which is primarily macular hole retinal detachments. This is a thrice operated case of RD elsewhere. So when we saw him, we decided to put, there was no other break. So we just put glue over the macular hole after settling the detachment, and you can see the result on the 5th post-op day. And he's still doing well. A young boy, chronic RD, during surgery we found there was no break except the macular hole, which was causing the detachment. So after settling the retina, we just put glue over the macular hole, the two components, and you can see in the first week the glue is seen, not seen on the 10th day. Macular hole closed, retina attached, and this is more than a year back. Oil is still in the eye. Again, sometimes the macular hole remains open, but the retina gets attached, which is very important anyway because patient gets back most of the peripheral vision at least. Like this patient, thrice operated for macular hole elsewhere, not developed a detachment because of the hole. So at the end of surgery, I had given them with the cuts, but at the end of surgery we put glue on the hole, and you can see on the first post-op day itself the retina is attached, the glue is on the macular hole, some subretinal glue. So this is a word of caution. With regard to technique, needle tip blockage is very common with glue, so check before you enter the eye that the needle is patent. Avoid excessive injection because it's transparent, so it's possible to over-inject. The blue component, which is the sealer protein, should be injected first because it's more viscous, so spillage is less. Subretinal glue in a macular location can cause atrophy and vision, adversely affect the visual outcome. Avoid excessive injection in any situation, it can keep the break open. To conclude, it is a useful adjunct in the management of complex RDs, especially when laser is not possible. And it reduces the need for post-operative positioning because the break is already closed and does not depend on the oil tamponade with no long-term complications. Thank you.
Dr. Mallika, the macular holes that you showed, they were all you were doing a reoperation for the macular hole, or was there anyone like
Yeah, I think most were resurgeries, or one was a very chronic RD of several years. So there it was more important to attach the retina than to think whether there would be some submacular infiltration with atrophy, because anyway they were blind.
So in macular hole associated RDs, we don't always require to plug that hole because the retina attaches as it is. So why did you think of putting the glue there?
Sometimes it may not attach, especially these are repeat cases. They have already failed.
So they were all repeat cases?
Almost all except the one chronic case.
Okay.
So they had already failed a few times. So obviously I thought it will fail again.
Any difficulty in under silicone oil putting glue?
That was only one case where we did it with where the oil was already there, and no, I had no difficulty at all. Because I think it is still heavier than oil. Oil is still lighter, so it still goes nicely over the break.
So I noticed that you put the...
You must be infusing silicone oil when you are doing under silicone oil, no? No.
No, oil is injected 5 minutes after the glue has been put. Once you put the glue, you wait 5 minutes so that there is no turbulence, and then we start oil injection. That is the last step.
Okay, after doing the surgery.
Yes. First the retinal surface has to be completely dry, then we put glue, wait 5 minutes without any manipulations, and then inject oil.
So I noticed that you mentioned that you drop the glue right on the break itself.
Yes.
So there have been other groups who do it a different way. They wait for the coagulum to form and then they kind of fold that coagulum onto the hole. So
Not
are you
required.
aware
Why
of...
should- Yeah, I know, I've heard all that.
Yeah.
But it's not required. You can just do
Because-
1 or 2 drops on each. I didn't show the videos in detail because of the time. But in each of those, just 1 drop over the break.
No, because I've heard the other LVP group actually where they fold the coagulum back, so I don't know how to put it.
Yeah, they used to do that, then now they're not doing. But also they might be doing it for macular holes.
No, just
regular
for the peripheral breaks.
No, then I think that all is not required.
And you use them for peripheral breaks as well, apart from the macular hole surgery that you mentioned. Did you use it for...
Mid-peripheral usually, mid-peripheral, because usually these are PDR cases where there is some bleeding, you are not able to laser.
Not PDR,
Not
regnatogens.
Not
Any
very
regnatogens,
peripheral.
because people have started using that and they say that they don't have to use oil and gas because the glue gives a very quick
Yeah.
closure of the break.
Well, I've used it
Did
only
you
for
try?
complex RDs. What you're saying is
Yeah,
probably the simple
the
RDs.
simple RDs.
I'm not talking about those. And in complex RDs, for peripheral breaks, they are already closed because you have put a band as well mostly, and you've done enough work there. So I've never had to use a peripheral, never. Mid-peripheral or macular.
And have there been any ERG studies done to prove, to show the safety in the
No,
macular
it's just 2
area?
years data I have. So
No, not yours, literature.
it was never been used earlier for.
Okay, so we don't know how toxic it is to the photoreceptors.
It's not been used long term earlier at all. No.
So the
there's-
macular area, we still don't know whether it's safe for the photoreceptors.
Because I have seen atrophy. I have seen
Yeah.
where it has gone subretinally.
Mm.
Fortunately, that was away from macula, but I've seen track of atrophy around that. So obviously, it will cause
It does need quite a bit of caution.
So you
to
cannot
put
use it
at
for regular macular holes, but where you're desperate to attach the retina, there you're not worried about some loss of macular photoreceptor. I lost some time because though I had given them edited videos,
Okay.
I had to edit them here.
Sometimes they are.
That's okay.
Thank you so much.
Thank you.